This is Harshita, a medical student in Katuri Medical College. So today we are going to discuss respiratory system. So from today onwards we are going to start systemic pathology. First, let us see what are the things that are present in the respiratory system. So first one, we have divided the respiratory system into 4 subparts. First one is obstructive lung disease, which includes introduction, emphysema, chronic bronchitis, bronchial asthma and bronchiectasis. And second one is destructive lung disease. In this portion, we are going to discuss pneumoconiasis, silicosis, asbestosis, fibrosis lung disease, pulmonary alveolar proteinosis. And the third one is granulomas. In this, we are going to discuss sarcoidosis, tuberculosis, pneumonia and miscellaneous diseases. And last and the most important one is lung tumors. In this, we are going to discuss benign and malignant tumors. So this is the overall view of the respiratory system. Okay, and today we are going to discuss the introduction of the respiratory system. Okay, so let's start the class. In the anatomy of the respiratory system, we have 2 components. First one is upper respiratory tract and the second one is lower respiratory tract. In the upper respiratory tract, we have nasal cavity, pharynx and larynx. Whereas in the lower respiratory tract, we are having trachea, primary bronchi and lungs. Okay. So this is the anatomy of the respiratory system. So let us keep a deep look at the lower respiratory tract. So for example, that is lower respiratory tract. Lungs, primary bronchi, and these are the secondary bronchi. This is the tertiary bronchi. Respiratory bronchi. Alveolar ducts and alveolar sacs. So in this, the most important thing that one must know is SNI. So respiratory bronchi, alveolar duct and alveolar sac. Let us discuss is BDS, like respiratory bronchi, alveolar ducts and alveolar sac. These 3 constitute and called as SNI. So in the disease called emphysema, alveolar SNI will get affected. So this is the introduction. And now let's move to the histology. Okay. So histology of the respiratory system, layers of respiratory tract. So there are 4 layers. Okay, and the mnemonic is M, S, M, C. So this is the mnemonic to identify the layers of the respiratory tract. M means mucosa, S means submucosa, M means muscularis and C means cartilage. Okay. So let's now go into a deep histology. Mucosa contains 3 parts. First one is epithelium, second one is lamina propria, and the third one is muscularis mucosa. And these submucosa have submucosal glands, and these glands will secrete the mucus. And we all know that mucus is useful for the protection of the layers of the respiratory tract from different substances. Okay. And the most important thing that we should remember is epithelium. What is the kind of epithelium that is present in the respiratory tract? It is nothing but the pseudo-stratified ciliated columnar epithelium. Okay. So it is pseudo-stratified ciliated columnar. So let us discuss. This is the basement membrane, and these are the pseudo-stratified columnar. Columnar, pseudo-stratified means they are falsely present at the layers. And they are also ciliated. So, ciliated, pseudo-stratified columnar epithelium. Pseudo-stratified ciliated columnar epithelium. So, this is the epithelium that is present in the respiratory tract. And make sure that this lines the entire respiratory tract except the vocal cords. So, pseudo-stratified ciliated columnar epithelium is not present in the vocal cords. Then the question is, what is the epithelium that is present in the vocal cords? It is nothing but the stratified squamous epithelium. Stratified squamous epithelium is present in the vocal cords. Okay. Up to now, we discussed very minimal points like anatomy, lower respiratory tract, and the histology. Okay. I hope you are clear up to now. And now let's go into the alveoli. Okay. Alveoli. These alveoli contains two kinds of cells. First one is the type 1 pneumocytes. Type 1 pneumocytes. Second one is the type 2 pneumocytes. In these type 1 pneumocytes are flat cells. These are constitute of 95% of the alveoli, and these are flat cells. And the type 2 pneumocytes are 5%. These are globular cells. And they produce, the most important thing is, they produce an important component called as surfactant. Okay. They promote healing after lung injury. For example, if lung undergoes any kind of injury, this surfactant is used for curing, and also it is an expander of the lungs. Okay. And now, so this is all for today. In this class, we discussed the overall part of the respiratory system, hence introduction. This introduction is very useful because in some of the diseases, the epithelium will get affected. In some of the diseases, the epithelium is get affected. So we should know the kind of epithelium present, and in some, the acini will get affected. And in some of the diseases, surfactant is getting affected. So it is very important to know the basics. Emphysema. So before starting it, let's know the obstructive lung diseases. Obstructive lung diseases. These obstructive lung diseases is divided into three types. Okay. First one is chronic obstructive lung disease. Second one is bronchial asthma. And the last one is bronchiectasis. So in this COPD, we come across two diseases. First one is emphysema, and the second one is chronic bronchitis. So before knowing what is emphysema, first let's learn the definition of the emphysema. What is the definition of the emphysema? There is irreversible enlargement. So first point is irreversible enlargement. Enlargement of the acines. Next one is, are there any specialties? Yes, there are two specialties. First one is destruction of the walls. Second one is, it is all happening without fibrosis. So the definition of the emphysema is, it is an irreversible enlargement of the acini, okay, with destruction of walls and with no obvious fibrosis. So this is the definition of the acini. So next one is pathogenesis. So the pathogenesis is very, very important. Pathogenesis means how a person is getting emphysema. For example, a patient came to you with a history of smoking, or you examined him, then you came to know that he is a deficient of alpha-1 antitrypsin. The person may be smoking or may be a deficient of alpha-1 antitrypsin. So because of this, there will be increase in the elastase activity. So because of that, there is the destruction of lung walls or lung architecture. So it leads to the disease we are learning now is emphysema. So a person came to you with a history of smoking and you get to know that he is a deficient or he may be having a deficiency of alpha-1 antitrypsin. Okay, so because of these two conditions, the elastase activity increases, which leads to the destruction of the lung architecture, which is called as emphysema. So depending on the location of the acini, we discussed that acini is getting affected. So what part of the acini is getting affected is very important now. So what part is affected? So first we should know the parts of the acinus. So acinus is having three parts. I already told you in the introduction part. If you not seen the introduction part, please go and see the introduction part. So acinus is having three parts. First one is respiratory bronchioles, alveolar ducts, and the third one is alveolar sacs. So these are the things that are present in the acinus. So depending on the location that is getting affected, the emphysema is divided into four types. First one is centrilobular. Centrilobular. Second one is pan-acinar. Pan-acinar. Third one is paraseptal. It is also called as digital. And the fourth one is irregular. Okay, everything lies in the name. Okay, everything lies in the name. So first let's divide it into four parts. So first let me draw the diagram. So this is the diagram, which is very, very important. So first one is tertiary bronchi. This is respiratory bronchi, and these are alveolar sacs and alveolar ducts. Okay, depending on the position that is getting affected, these are divided into four types. So first one is centrilobular. So what is getting affected? In these three parts, what is the center one? So if we think that this is the first one, this is the second one, and this is the third one, this respiratory bronchioles is getting affected. So this is centrilobular. So the important points are, this is the most common one. So this is the most common one. Second point is, The area which is affecting is nothing but the respiratory bronchiole. And the third one is why the patient is affecting with the centrilobular acini. Means there are only two conditions. First one is smoking and the second one is alpha-1 antitrypsin. And here he is affecting by smoking. And the last one is if it is a lung, majorly the upper lobe of the lung is getting affected. So this is all about the centrilobular. Okay. And the second one is, let me change the color. Second one is pan-acinar. Pan-acinar means all the layers are getting affected. So what are the parts are getting affected? The parts are nothing but the respiratory bronchi are getting affected, and alveolar sacs and alveolar ducts all are getting affected. Okay. And now entire acini is getting affected. Entire acini. Entire acini is getting affected. And the next one is, what is the reason? Reason is nothing but the deficiency of alpha-1 antitrypsin enzyme. So this is the main reason of getting pan-acinar. And next one is, if this is a lung, majorly the lower lobe of the lung is getting affected. Okay. And the third one is paraseptal or digital. The name itself says it is digital, means only the alveoli is getting affected. Okay. Second one is, it is due to the spontaneous pneumothorax. Okay. And the fourth one is irregular. What is irregular? Irregular enlargements. So enlargement may be in the respiratory bronchioles or alveolar sac or alveolar ducts. Okay. It is irregular. So it is the most common histological type. And here the any part of the lung can affect it. Any part, because it is irregular. Any part. I hope you understand. So this is all about the emphysema. So first we saw the types of obstructive lung diseases and next the emphysema. First we learn about the definition. So definition is very important. We learn the definition, pathogenesis and the types. And we have the complications caused by the alpha-1 antitrypsin deficiency. Okay, in this, the first point is it is autosomal recessive, and the thing that we should know is organs affected. There are majorly two organs. They are lungs and liver. They both are getting affected in this alpha-1 antitrypsin mechanism. In the lungs, in the last class we saw that the most affected part is pan-acinar emphysema. And the liver, we see cirrhosis. And the mnemonic that I am giving to is PAN. P-A-C. So, this is pan-acinar. This is autosomal recessive and also alpha-1 antitrypsin. So, with this you can remember it very well. Okay. And let's go to the genetic value. Like, why there is a deficiency of alpha-1 antitrypsin. So genetics. Please do remember the most important chromosome is chromosome 14. On chromosome 14 there is a gene for alpha-1 antitrypsin. So it is getting affected. Normally the genotype is normal genotype. It is PIMM, but in abnormal one or in diseased one, it is PIZZ. Now let's go into the histology. In histology, you will find broken alveolar walls. Means the broken alveolar walls can be seen in the deficient people with alpha-1 antitrypsin. It is also known as floating septa. Okay. And the next one is clinical features. Let me explain you with a diagram. Okay. Okay. So the clinical features are dyspnea, like for mouth we give dyspnea, and pink puffers. Pink puffers means there are reddy cheeks. For example, we are identifying them as pink puffers. And barrel shaped chest, and pierced mouth, lips, birds lip breathing. And the last one is flattened diaphragm. So if a patient comes to you, by seeing the clinical features, you can easily come into a conclusion that it is alpha-1 antitrypsin deficient. How? He will have pursed shaped lips, like he is blowing a balloon, he will have breathing. And second one is pink puffers. He looks somewhat pink puffers, and the diaphragm will be flat, and you can identify an barrel shaped chest. So these are the clinical features of the alpha-1 antitrypsin deficiency. So this is all for today. So let me summarize it. Autosomal recessive, two organs are affected, and the gene affected is chromosome 14. Normally it may contain PIMM gene, and in an abnormal person you can see PIZZ gene, and histologically you can see all broken alveolar walls. Chronic bronchitis. This is an important topic that comes under the obstructive lung diseases. So the definition of chronic lung diseases is okay, and the definition is there is a person. This person is getting cough, and the cough is at least 3 consecutive months and 2 consequent years. But we should not know any kind of cause. Like he is having 3 months continuous cough for 2 consequent years, but without any cause. Then we can suspect the person may be having chronic bronchitis. So the definition is at least 3 consecutive months for at least 2 consequent years. Absence of any identifiable cause. We can make a differential diagnosis of TB in this condition also. Next one is pathogenesis. For example, the person is smoking. Smoke, the mucous glands will irritate and undergoes hypertrophy. Okay, because of this hypertrophy, there will be increased mucus production, and the mucus is produced, there will be productive cough. For example, the person is smoking. Because of the smoking, there will be irritation in the mucosa, and the mucosal glands will undergo hypertrophy. Because of this hypertrophy is nothing but the increase in the size of cell. Means the size of cell is increasing, so there will be more production of mucus. As the mucus is producing more, there will be productive cough and increased Reid index. So it is very important to know what is this Reid index. For example, let us discuss, this is epithelium. So this is the epithelium you are seeing here. Okay, this is the basement membrane, these are the glands, and this is the cartilage. Okay, and the Reid index formula is the ratio of the mucous gland to the distance between the basement membrane and the cartilage, means BC. This is B and C. BC is nothing but the width of the mucous glands, and AD is nothing but the distance between the cartilage and the basement membrane. So the ratio of these both will gives rise to the Reid index, and the normal value is 0.4. It is very important. Please note it down. Okay. In chronic bronchitis, there will be increased Reid index. Okay. The normal Reid index is 0.4. So here the most important thing you should understand is there is hyperplasia of goblet cells and the thickening of the basement membrane. So these are the important features that you should know about the chronic bronchitis. Bronchial asthma. It is a very important topic which comes under the obstructive lung diseases. In the previous classes, I discussed about the emphysema and the chronic bronchitis in a very easy manner. If you didn't see the video, please go back and see the video first. Okay, let's start the video. Chronic bronchitis. Okay, let's start the class. And the definition of the bronchial asthma is due to any kind of reversible bronchoconstriction or inflammation of airways, there will be hyper-responsiveness. Okay, because of this hyper-responsiveness, we will get bronchial asthma. As it is hyper-responsiveness, we can say that this is type 1 hypersensitivity reaction. So this is type 1 hypersensitivity reaction, and the most important genetic components are 3. Okay, please do remember these all. So first one is there is atrophy in the gene which is present in the chromosome 5. So this chromosome 5 is very important. Gene for atrophy is on chromosome 5, and polymorphism in interleukin 13 and ADAM 33 gene matrix metalloproteases. Okay, and the third one is as the severity of the bronchial asthma increases, there will be increased association of YKL40. Okay, so these three are very important. First, okay, and come now let's see the pathology. In this pathology, we see CQ, means we see 3 kinds of bodies which starts with C. First one is Crushman spirals. Second one is Charcot-Leyden crystals, and third one is Crayola bodies. Okay, first one is Crushman spirals. Spirals name itself says that something is in spiral shape. What is in spiral shape? At present we are discussing about the respiratory system. In respiratory system, we always come across the word called mucus. So there is world appearance of mucus plugs. Like mucus is arranged in a kind of circular shape. These are called as Crushman spirals. Next one is Charcot-Leyden crystals. They are nothing but the eosinophilic membrane proteins. These eosinophilic membrane proteins are called as galectin 10. Do remember like this. Crystals are something like solids. These solids are nothing but the proteins. So what is this protein? This protein is galectin 10 protein. Okay. This is nothing but the eosinophilic membrane protein. And the next one is Crayola bodies. These Crayola bodies are nothing but the slogged mucous epithelium. Mucous epithelium is filled with, epithelium is filled with the mucus. This is the appearance of Crayola bodies. So please do remember this. In pathology, you get to know. In pathology of the bronchial asthma, okay, you will observe 3 C's. Okay, now let's compare the histology of a normal lung and the lung that is affected with the bronchial asthma. Okay, by seeing these 2 pictures, you can understand everything. For example, this is the mucus lining. Okay, this is the mucus lining. Please do observe the mucus lining in both the images. It is very thin, and here it is very thick. Next one is epithelium. In epithelium, you can see the difference of goblet cells. In the normal, we are having minimum goblet cells. In this bronchial asthma, we are having more number of goblet cells. And the basement membrane. Thickening of the basement membrane will increases. And lamina propria. In the lamina propria, we can observe mast cells, neutrophils, macrophages and eosinophils. These are all the cells that we observe in the inflammation. So all the inflammatory cells will come and occupy in the lamina propria, and then we can observe there is increase in the smooth muscles. Here there is only one layer of smooth muscle, but here there are many layers of smooth muscles. And if you come down, we can observe the increase in the number of glands. Okay, this is cartilage. And here we can observe number of glands increases in the bronchial asthma. So if you come to a finalization, so altogether this process is called as airway modeling. Like the airway is getting modified or modifying itself. Okay, how it is modifying? There is increase in the mucus production. So mucus production should be increased. How? Due to the hyperplasia. Like goblets are undergoing division. Because of the division, there is increase in the mucus production. As the goblet cells are increasing, to bear that goblet cells, thickening of the basement membrane is also increases. To bear that goblet cells, thickening of the basement membrane is getting increased. And in the lamina propria, we can see inflammatory cells. Inflammatory cells are nothing but the mast cells, neutrophils, macrophages and eosinophils. And there will be smooth muscle hypertrophy. To bear, remember like this, to bear all the inflammatory cells in the lamina propria, the smooth muscle is getting hypertrophy, like the size of the muscle is getting increased. And next one is submucosal gland hypertrophy or hyperplasia. The glands present in the submucosa are getting increased or getting divided so that it is suitable for exchange of gases. So these are all the histological changes that we observe in the bronchial asthma patient. Bronchiectasis. So bronchiectasis. The definition of the bronchiectasis is there is abnormal permanent dilatation of bronchi and bronchioles. Okay, there is a dilatation of bronchi and bronchioles. So these can be caused because of two types. One may be congenital or genetic, and the next may be acquired. This congenital is very important because in this we are having syndrome. What is this syndrome? This syndrome is Cartagena syndrome. And the second one is cystic fibrosis. And in the acquired ones, we get obstructive and infections. In this obstructive, we get foreign bodies and tumors. These foreign bodies and the tumors will obstruct the airway. So, these are called as obstructive. Okay. Because of these, there will be dilatation. The dilatation may be due to the obstruction or may be due to the infection or may be due to the Cartagena syndrome or cystic fibrosis. Okay. Now, let's see about the Cartagena syndrome. It is immotile cilia syndrome. The name itself says it is the other name of Cartagena syndrome. The name itself is saying something. What is it saying? There is immobility of the cilia. Means there is something defect in the cilia. Okay. The main action of the cilia is to move, but it is not able to do its main function. So, it is functionless cilia. Okay, the benign arm of cilia is defected. So, it is also called as immotile cilia syndrome or the primary ciliary dyskinesia. So, these are the other names of the Cartagena syndrome. Okay, this Cartagena syndrome is also having a triad in which we are having bronchiectasis, sinusitis and situs inversus. Okay, these three comprises a triad in the Cartagena syndrome. In the affected male or female, we can see infertility. Okay, and let's see the complications. The complications are the lung abscess. The person may get lung abscess or brain abscess or emphysema or amyloids. And the amyloids that we see are AA type of amyloids. These are the complications of the bronchiectasis. Now let us see. For example, this is the respiratory system that we are having. Here we are having normal lung and here we are having a lung that is affected with the bronchiectasis. Majorly, the most affected part is the lower part. Lower lobe mostly get affected due to this bronchiectasis. For example, if you send a probe inside the respiratory system, the probe will stop 2 to 3 centimeters before entering the pleura. Means before entering the pleura, the probe will stops because there is constriction. The probe is not going. For example, this is the trachea. This is the probe. Okay. For example, this is the trachea. The trachea is like this and this is the probe. So the probe is not able to move up to the pleura. There is 2 to 3 centimeters before reaching the pleura. Okay, so this is the flow. And now there is dilatation in the trachea. The trachea is getting dilated. So this is the normal. So in normal, this is the one. There is somewhat construction here. In this picture, in bronchiectasis condition, there will be dilatation. Because of this dilatation, the probe will enters the complete area and reaches the pleura because of this dilatation. So the probe will reach the pleura in the bronchiectasis condition. In the normal condition, the probe will not reach the pleura. So this is all about the bronchiectasis. Now let's wind it up. Bronchiectasis is nothing but the dilatation of the bronchi and bronchioles. It is a permanent dilatation and it is due to an congenital cause. It may be due to an congenital cause or maybe an acquired cause. In congenital, we are having two situations. First one is carcinogenous syndrome. Next one is cystic fibrosis. In acquired, we are having obstruction and infection. Maybe due to this congenital or acquired, we are having dilatations. In obstruction, maybe due to the foreign bodies or maybe due to any kind of tumors. So carcinogenous syndrome is also called as immotile cilia syndrome, means the cilia, the dining arm of cilia is defected. So there is no movement in the cilia, and the triad we can see is bronchiectasis, sinusitis and situs inversus. The complications are lung abscess, brain abscess, emphysema and amyloids. Okay, and the probe test that we see, and the probe test give the difference between the normal probe and the bronchiectasis patient. Okay. These restrictive lung diseases will lead to the decrease in the total lung capacity. The normal total lung capacity is 6 liters, but in these restrictive lung diseases, the lung capacity will decreases. These restrictive lung diseases are divided into 4 types: fibrous restrictive lung disease, pneumoconiasis, granulomatous disease, and the smoking associated diseases. Fibrosing restrictive lung diseases. These are furtherly divided into 3 types. One is idiopathic pulmonary fibrosis, means we don't know the reason. Second one is non-specific interstitial pneumonia, and the third one is cryptogenic organizing pneumonia. This cryptogenic is also mean by we don't know the reason, and idiopathy is also by unknown cause. Okay, so these are the 3 types that are present in the fibrosis. And next one is pneumoconiasis. In this pneumoconiasis, the most important things that we should remember is the size of the particle, solubility, duration and smoking. If the particle size is 0 to 5 microns, it is the most pathogenic condition. Means the smaller the particle, the more is the pathogenicity to the lung. Okay, so these pneumoconiasis is divided into 3 types. One is cold worker pneumoconiasis, second one is silicosis, and third one is asbestosis. These, for example, this is lung. This lung is divided into 2 lobes or 2 parts. This is the upper part, this is the lower part. In cold worker pneumoconiasis and silicosis, the upper part is majorly affected. Okay, whereas in the asbestosis, lower part is affected. These are the important points that you should remember. Next one is granulomatous diseases. These granulomatous diseases are also divided into different types. First one is sarcoidosis. Second one is hypersensitive pneumonitis. Third one is tuberculosis. Fourth one is pneumonia, and fifth one is other infections. And the next one is smoking associated diseases. So these are the diseases that are present in the restrictive lung diseases. Okay. Let's go into the cold workers pneumoconiasis. Cold workers pneumoconiasis. The name itself is saying us something. What is it saying? It is caused to coal mine workers. Means the people who are working in the coal mines are majorly affected. And the what part of lung is affected is upper lobe of the lung is getting affected. They are furtherly divided into 2 types. First one is simple and second one is progressive. In simple, we will get coal macules and nodules. Coal macules or nodules are present. These are nothing but the coal is getting accumulated in the macrophages. Okay, so these leads to the cold macules. And the next one is progressive cold worker pneumoconiasis. In this, entire lung is affected. So entire lung is affected means there is much destruction to the lung. Like as the person is continuously exposed to the coal mines, it leads to the progressive coal worker pneumoconiasis. And the most important point that one should remember is Kaplan syndrome. This Kaplan syndrome is very important. There is a chance of getting it in your NEET examination. What is this Kaplan syndrome? For example, if a person is having, if a person is having coal worker pneumoconiasis or silicosis with addition to the rheumatoid arthritis, we say that he is suffering from Kaplan syndrome. Syndrome is group of symptoms. Like what kind of symptoms he is having? He is having the symptoms that are related to the rheumatoid arthritis and coal worker pneumoconiasis or silicosis. Okay, that is silicosis. This is also called as miners or grinders disease. Means the people who are working in the mines will get this disease. Okay, seen in sand blisters. Yeah, this is the most common occupational disease that we can get. Most common occupational disease. And the most important question is what part of the lung is getting affected. For example, this is a lung. Sorry, it's not coming. This is a lung. This is the upper lobe and this is the lower lobe. What part of the lung is affected in silicosis is very important. I explained this in the last class. If you not seen the last class, please go back and do watch it. Okay. In silicosis, the most affected part is upper part of the lung. Upper part of the lung will get affected in silicosis, and it is similar to the complaints. The chief complaints of the patient or the symptoms of the patient are very much similar to the tuberculosis. Okay, please do remember that. And if we go into the complications, there are many complications for this silicosis. First one is lung cancer and second one is enlargement of lymph nodes. So these are the very important complications of silicosis. Okay, now let's observe what kind of structures that we can see grossly or in X-ray or histopathology or microscopy and biopsy of silicosis. Okay, yeah, let me zoom this out. Okay, this is the lung and these are the structures that you are going to see in different types of identifications. Okay, first one is grossly. In gross, we can see fibrotic nodules and collagenous scar. Like if it is a lung, we can see scars and collagen nodules grossly. Second one is X-ray. If eggshell calcification is seen in the patient suffering with silicosis. Next one is histopathology. In this histopathology, you will see whorled collagen fibers. Collagen fibers are arranged in a circular manner, and in polarized microscopy, you can see SiO2 particles. Silica particles can be observed in polarized microscopy, and if you send the lung to the biopsy, there you can observe fried egg appearance can be seen. This mnemonic you can easily understand or easily remember. Asbestosis. Asbestosis, it is a very important topic in the respect to lung diseases. Okay, or occupational lung diseases. In this asbestosis, it is mostly present in the construction workers. The people who do construction work are more prone to asbestosis, and mostly or shipping industries, and mostly lower lobe of lung is affected. In coal worker pneumoconiasis and in the silicosis, the upper part of the lung is affected, whereas in asbestosis, lower part of the lung is getting affected. Next one is asbestos fibers. Okay, there are two types of fibers. Depending on what kind of fiber entered into the lungs, the disease varies. First one is serpentine fibers. Name itself is saying that they are flexible and spindle-like. Means they can be easily degradable. As they are easily getting degradable, there is no harm. Okay, and in the second one is amphibole fibers. and in these fibers they are not easily degradable, so they get deposit and cause the asbestosis. So if a person is more prone to the amphibole fibers, he is more prone of getting this asbestosis. Okay, I hope you are clear up to now. These are other diseases. There are many other diseases that we get from these asbestosis. So one such disease is pleural plaques. There will be presence of plaques in the lungs. Pleural plaques. Second one is pleural effusion. Effusion means accumulation of the fluid or any kind of materials. Or we will get lung cancers. These lung cancers are due to the hypertrophy of the glands. Means as the gallbladder glands increases, it leads to the adenocarcinoma. Adenocarcinoma is nothing but the carcinoma of the glands. Next one is malignant mesothelioma. This malignant mesothelioma is most specific malignancy. In this, you will observe psammoma bodies. These psammoma bodies are also very, very important. Okay. Third, serous histoadenocarcinoma of ovary. P for papillary carcinoma of thyroid, another P for papillary renal cell carcinoma, and another P for prolactinoma. These are and M for meningioma. These are the conditions in which we can observe psammoma bodies. Okay. And next one, not only the lung related diseases, but also we will get laryngeal cancer, gastric cancer, and renal cell carcinoma due to this asbestosis. And the most important topic one should remember is histopathology. In this histopathology, we will identify asbestos bodies or ferruginous bodies. Ferruginous means related to iron. If the asbestosis, this is a asbestosis, if it is lined by iron, then it is called as ferruginous bodies. Okay, they are in dumbbell shape. Ferruginous bodies are in dumbbell shape. And the other diseases of the pneumoconiasis are beritosis, which is the toxicity of the barium, bicyanosis, toxicity of the cotton, bagasosis, toxicity of sugarcane, siderosis, iron toxicity, and berylliosis, beryllium toxicity. In this beryllium toxicity, we can observe non-caseating granuloma. In tuberculosis, we observe caseating granuloma. In asbestosis, you observe non-caseating granuloma. Okay, so this is all about the asbestosis. So fibrosis restricted lung diseases. So in this fibrosis restricted lung diseases, they are classified into three types. First one is idiopathic pulmonary fibrosis, second one is non-specific interstitial pneumonia, and the third one is cryptogenic organizing pneumonia. So idiopathic means the reason is not known. It is also called as usual interstitial pneumonia. And the next one is non-specific interstitial. First one is usual, next one is non-specific, and the third one is cryptogenic organizing pneumonia. In the first one, we can see TGF beta mutation and fibrosis takes place in the lung parenchyma, whereas in the non-specific interstitial pneumonia, we see connective tissue disorder. There is disorder in the connective tissue in non-specific interstitial pneumonia. And the last one is cryptogenic organizing pneumonia. In this, we can observe BOPS, means bronchiolitis obliterans organizing pneumonia. Okay, and the most important point that one should remember is histology. In these fibrosis restrictive lung diseases, we can observe Masson's bodies. These Masson's bodies are nothing but the loose fibrous plugs in the lung parenchyma. Sarcoidosis. So let's start the class. Sarcoidosis is mostly seen in the Western countries, and the diagnosis is also exclusion. Okay, it majorly occurs in females. Mostly females are prone to the sarcoidosis, and it occurs in the persons having 30 to 40 years of age. Okay, and the clinical features are multi-system disorders, means there are many systems that are getting affected in the sarcoidosis. For example, let's start from the eye. In eye, we can see uveitis. This sarcoidosis is a multi-system disorder, means For example, a patient came to you with a clinical features of uritis, sickle syndrome and keratitis. These are the diseases that we get in a person if he is affected with the sarcoidosis. Next one, we can also see salivary gland enlargement. There will be involvement of the salivary glands. They may be sublingual, submandibular or others, and the patient will come with a high temperature, means he will present with fever. There will be involvement of the skin. Hilar lymph nodes can also get enlarged. The patient may get weight loss. There may be genital involvement and bone marrow involvement. Okay, but the most important thing that one should remember is the most affected organ in sarcoidosis is lung. Okay, majorly if a patient come to you with these clinical features, make sure that you keep sarcoidosis as your differential diagnosis. Okay, next let's move to the pathogenesis. In pathogenesis, the most three important points that one should remember is it is type 4 hypersensitivity reactions, means there is cell mediated immunity is seen or is get affected. And next one is there will be increase in the CD4 and helper T cells involvement, and there will be granuloma formation also. Granuloma formation we can see in the tuberculosis and this sarcoidosis. Okay, and here HLA-A1 and HLA-B8 association can be seen. Okay, in this pathogenesis you have to remember 3 points. First one is it is type 4 hypersensitivity. Second one is CD4 and Th1 cells will increases, and the third one is HLA-A1 and HLA-B8 association can be seen. Okay, next let's go into the inclusion bodies. There are 2 points that we should remember is in sarcoidosis we can observe asteroid bodies. This is the most important. As star shaped bodies we can see, and next one is basophilic Chowman bodies. Basophilic Chowman bodies. What are these Chowman bodies? These are nothing but the calcium granules, or there will be more concentration of calcium which is basic in nature. Okay, C for calcium, bodies B for basic in nature. So these are Chowman bodies. Next one is biopsy. If you take the biopsy, we have already learned that granuloma is seen. What kind of granuloma is seen? The granuloma we can see is naked. Okay, let me zoom this. The granuloma we can observe is naked granuloma can be seen. Okay, naked granuloma can be seen. Why it is naked? Because there are absent of lymphocytic collar. Lymphocytes are absent here, so the granuloma is naked in the sarcoidosis, whereas in TB there are presence of giant cells, so it is not naked. Okay, and the second one, let's see what type of granuloma. The epithelioid cells, these are the epithelioid cells which are slipper in shape. These are slipper in shape, and at the center we get the non-caseous granuloma. In TB we get the caseous granuloma or caseous necrosis. Sarcoidosis you can observe the non-caseous granuloma. Okay, the points that you should remember is it is naked. Why it is naked? Due to absence of lymphocytic collar, and what it is contains, they are containing slipper shaped epithelioid cells and the non-caseous granuloma. Okay, now let's go into the biochemical test. In biochemical test we already discussed that there will be increase in the CD4 cells and CD8 cells ratio. The ratio will get increased because CD4 cells are getting increased. Okay, numerator is getting increased, hence the overall ratio will get increased. Next one is Kaiman's test is positive. Next one is serum calcium is positive. Why serum calcium is positive means here we can observe Chowman bodies. These Chowman bodies are made up of concentrated calcium, hence serum calcium concentration increases, and this is metastatic calcification, and there will be angiotensin converting enzyme will get increased in this syndrome. Okay, topic that is tuberculosis, not only in pathology, it also very important in microbiology and the drugs are also important in pharmacology, that is tuberculosis. We all know that it is caused by Mycobacterium tuberculosis. Okay, for example, you are sitting in the OP, a person came to you with a chief complaints of fever. A patient came to you with fever, which is very common in many diseases, weight loss, chest pain, dyspnea, and cough. With these, if the person is having night sweats, make sure that you suspect tuberculosis, because the person is having weight loss along with the night fevers, chest pain, dyspnea. These are the clinical symptoms for tuberculosis, and the most virulence factor we can observe here is COD factor. Okay. Now let's go into the investigations. You met the patient and you are suspecting either it may be tuberculosis, and you sent the investigations like FNAC of lymph nodes, acid fast strain, and biopsy. Okay, in FNAC, like we have taken the aspiration. In that aspiration you can observe caseous granuloma, means the granuloma is containing caseous necrosis inside this, which is cheesy like material. Okay, it is a classical symptom of tuberculosis. Next one is you can observe the acid fast bacilli in Zn stain. There are many organisms that may lead to this. For example, they are Cryptosporidium, Isospora, and Nocardia. These are the organisms other than the Mycobacterium tuberculosis that can cause or that can be observed as acid fast bacilli. Okay, why this is happening? Because of the mycolic acid. Okay, and the last one is biopsy. You have taken a lung biopsy in which you can also see caseating granuloma and giant cells. What type of giant cells? Langerhans giant cells can be observed. You also see heart shape or necklace. You can observe like this. This kind of nuclei, okay, this kind of nuclei, heart shape or necklace like nuclei in the biopsy. So these are the identifications in the investigation that you send to the lab. Next one is types of tuberculosis. There are majorly 3 types of tuberculosis. First one is primary tuberculosis, means first time the patient is getting affected. What kind of patient he is? He may be a child. Okay, as a child he is getting affected, hence it is called as primary. Next one is secondary, and the third one is military. Okay, let's understand them one by one. Okay, there is a child, for the first time he is exposing to the Mycobacterium tuberculosis. Okay, it leads to the primary tuberculosis. Okay, this is a lung, this is the upper lobe, and this is the second lobe. Mostly the lower part of the first lobe and the upper part of the second lobe. Okay, these center lobe will get affected in the primary tuberculosis, hence this is called as Gons foci. Okay, the center part is getting affected, it is called as Gons foci. With the Gons foci, if there is involvement of any kind of lymph nodes, okay, then it is called as Gons complex. Focus with the involvement of lymph nodes, it is converting into complex. Okay, if there is involvement of fibrosis and calcification, these complex will convert into the Ranke's complex. And if there is the involvement of other organs like brain, liver, pulmonary veins, as if brain is getting involved, it is called Rich complex. Liver is involving Simon's complex. Pulmonary vein is involving Weget's complex. These are the other names that one should know. Second one, secondary tuberculosis. There is reactivation. Already the child is affected with tuberculosis once, and again he is affecting. There is reactivation, hence it is called as secondary tuberculosis. In children it takes place. This is clavicle, and the next part you should remember is this is clavicle. Above the clavicle supraclavicular, below the clavicle infraclavicular. If the lesion is above the clavicle, it is called as Paul's focus. If the lesion is below the clavicle, it is called as Asman's focus. Above it is P, below it is A. In the middle it is C, PCA. Okay, if it is above, it is called as Powell's complex, and if it's below, it is called as Asman's focus. And the last one is miliary tuberculosis. The name itself is saying there will be 1 to 2 millimeters of millet shaped nodules. So it is poor prognosis, and there will be involvement of other organs, The other organs will get involved because of this hematogenous route, means the mycobacterium in the lung will reach to other organs like brain, liver, anything through blood, RBC. Through RBC, the disease is getting spread. So these are the 3 types one should know about the tuberculosis. Pneumonia. It is an infection in which lung parenchyma is getting affected, and there are 2 kinds of pneumonias. First one is community acquired pneumonia, and the second one is hospital acquired pneumonia. In community acquired pneumonia, the most causative organ is streptococcus pneumonia, and the second one in which hospital acquired pneumonia comes is staphylococcus aureus. The first one it is streptococcus pneumonia, and the second one it is staphylococcus aureus. Okay, this pneumonia is classified into 2 types. First one is lobar pneumonia. Here entire lobe is getting affected. Second one is lobular bronchopneumonia. There will be minor lesions in the lobes, hence it is called as lobular. And the classification is of 2 types. First one is typical pneumonia, and second one is atypical pneumonia. Depending on the organism that is affecting the lung, they are divided into 2 types. Typical, in which bacteria is involving, and lots of exudate we can see, and the most common defense mechanism we can observe is neutrophils will present. And in atypical we can see virus. A we will write like this, we will write reverse. Okay, in atypical we can observe involvement of virus, and there will be less exudate, and lymphocytes will appears here. Like we can see more number of lymphocytes. Okay. Next one is stages of pneumonia. There are 4 stages of pneumonia. They are C, R, G, R. C, R, G, R. Congestion, red hepatization, grey hepatization, and resolution. Depending on the type of cells and the color of the lung, they are divided. First one is congestion. In congestion, RBC is getting involved, hence it is called as congestion. Next one, red hepatization. It is due to the more involvement of the RBC or destruction of the RBC, and it happens in 2 to 4 days. Here we have named here hepatization. Why? Because the consistency of the liver is seen here. The consistency is due to this fibrin. As the fibrin is more, the consistency is like liver, and red color is due to RBC, hence it is called as red hepatization. Next one is grey hepatization. The RBC is getting disintegrated, RBC is breaking down, hence the color is grey in color, but the consistency is same as the liver. Okay, hence it is called as grey hepatization. Next one is resolution. This takes place in 5 to 10 days and is the most common output. So these are the things that you should remember: congestion, red hepatization, grey hepatization, and resolution. First one is 1 to 2 days, second one is 2 to 4 days, third one is 5 to 8 days, and the last one is 8 to 10 days. Okay, and the color change is due to the RBC and the RBC disintegration. And if you send it to the biopsy, you can see inflammatory cells and the alveolar engorged. Inflammatory cells may be of neutrophils or lymphocytes depending on whether it is typical or atypical. So this is all about the pneumonia. Pulmonary alveolar proteinosis. This is the surfactant disorder. In the previous section, we discussed that there are 2 types of cells lining the alveoli, that is pneumocyte type 1 and pneumocyte type 2. These type 2 will produce as the surfactants. If there is any defect in this surfactant, this pulmonary alveolar proteinosis is caused, and this is very rare disorder. Okay, next this is divided into 3 types. First one is congenital or neonatal, second one is autoimmune pulmonary alveolar proteinosis, And the third one is secondary pulmonary alveolar proteinosis. The first one is congenital or neonatal. Congenital means there is defect in the gene. So what type of gene is getting defected is GMCSF and its receptor. This is the gene GMCSF. Okay, this is the gene getting affected or mutation is taking place in this gene. Okay, so let's see the pathogenesis. There is mutation in the ABCA3 gene because of which defect in development of laminar body. So it defects the production of type 2 pneumocytes which results in surfactant abnormalities. These are the steps that are getting involved in the congenital or neonatal pulmonary alveolar proteinosis. Okay, first there is defect in the ABCA3 gene because of which laminar body is not getting developed. So pneumocytes type 2 are getting affected, due to which surfactant is not produced much. Next one is autoimmune pulmonary alveolar proteinosis. This is the most common one. So 90% of the population is getting affected here. Here also there is defect in the GM-CSF signaling pathway because of which surfactant accumulates in the intrabronchial space. Surfactants is getting accumulated but surfactants is not getting utilized. So there is autoimmune pulmonary alveolar proteinogenesis. And the third one is secondary pulmonary alveolar proteinogenesis. It is secondary, which is very rare, and hematological malignancies can be seen. This is homogeneous pink color in the alveoli. We can find in the alveoli, we can find an homogeneous pink color which gives an identification point to the secondary pulmonary alveolar proteinosis. Okay, so this is all that one should know about the pulmonary alveolar proteinosis. Lung cancers. They are squamous cell carcinoma. This is the carcinoma present in the non-small cell carcinoma. In the last class, I explained everything about the lung carcinomas. If you not watch them, please go back and watch the video before you start in this video. So, squamous cell carcinoma. This carcinoma is most commonly seen in males and it is associated with smoking. So, the hint I am going to give you is squamous cell carcinoma, okay, squamous cell carcinoma and small cell carcinoma all starts with S. So, remember that they are associated with smoking. Okay, next one is they are centrally located. They are centrally located in the lung. If this is lung, the carcinoma is centrally located and you can observe the cavity lesions and intrabronchial mass producing obstruction. Due to any mass in the lungs or bronchia, there will be obstruction. Cavity lesions are produced and due to the bronchial mass, there will be the obstruction. Now let's go into the pathogenesis. Here pathogenesis is there is mutation. Mutation in chromosome 3p, qp and 17p. And there will be mutation in the p53 gene, rb gene, CDKN2A gene, CDKN1A gene. So these are the genes that are getting mutated in the squamous cell carcinoma. Okay. Next one is association. Squamous cell carcinoma is associated with the paraneoplastic syndromes. These are related to the parathyroid hormones which is produced by peptides, and precursor lesions are squamous cell dysplasia and carcinoma in situ. These are the precursor lesions of the squamous cell carcinoma. Next, identification points. In H&E stain, you can observe, these are the most important things that one should remember. You can observe desmosomes and keratin pearls can be seen. Keratin pearls are like circular shaped calcified pearls or these are circular shaped keratinized pearls, and desmosomes like these are filled with fibers. Okay, these are depending on the type of depending on the differentiation, this squamous cell is divided into three types. First one is it is well differentiated, second one is moderate differentiated, and the third one is poorly differentiated. Differentiation means what? differentiation is nothing but the maturation. It's a kind of word that we use for maturation. Okay, how different it is from its parental cell. Okay, so in well differentiated, you can see keratin pearl is completely seen here. Okay, in moderate differentiation, you can see only keratinization, and in poorly differentiation, keratin pearls are not seen. As the pearls are not seen, keratin pearls is the identification. Here, we not able to see the identification feature here. So, these can be, so diagnosing this poorly differentiated squamous cell carcinoma is very hard. To overcome this, we can diagnose it by cytokeratin, P63 and P10 markers. Okay. So, this is all about the squamous cell carcinoma. Adenocarcinoma of lungs in respiratory system of pathology. So this is the most common lung carcinoma, mostly seen in the women's. Okay, and this is seen in non-smokers. In the last class, I told about the squamous cell carcinoma, and in this I discussed many points. If you not seen the video, please go back and watch the video first. In squamous cell carcinoma and small cell carcinoma, as they are starting with S, they are strongly associated with the smoking. In adenocarcinoma, they are non-smokers also getting affected due to this. And if this is lung, the lung mostly present in the periphery of the lung. So, it is periphery located. And paraneoplastic association is migratory thrombophlebitis. So, this is seen in the adenocarcinoma of lung. And the genetics. In squamous cell carcinoma, the genetics affected are chromosome 3p, 9p and 17p, and also RB gene, P53 gene are getting affected. Whereas in adenocarcinoma, they are EGFR gene, ALK gene, METM gene, KRAS and RET, red gene are also getting affected. To remember this is the hint I am giving you. Ear met KRAS. Ear met KRAS. So, MET is the gene, KRAS is also gene. Ear. E for EGFR, GFR, you know it, right? Glomerular filtration rate. So, EGFR, this is the hint that you can remember in adenocarcinoma of lung. And the precursion lesions are very important. Here, the precursion lesions are atypical adenomatous hyperplasia and adenocarcinoma in situ. So, let's discuss them one by one. Atypical adenomatous hyperplasia. So, these are the lesions of below 5 millimeters. Okay. So, this is the alveolar epithelium. Here you can find dysplastic pneumocytes. So, pneumocytes are dysplastic. There is no maturation in the, or there is no production in the pneumocytes. Hence, this is called as atypical adenomater hyperplasia. Hyperplasia means increase in the number of cells. Okay, the cells are getting increased. But what types of cells are increased? Dysplastic cells means this. You can remember it like defected cells. Next one is adenocarcinoma in situ. This adenocarcinoma in situ, it is bronchoalveolar carcinoma which is less than 3 centimeters. And here the important feature one should remember is, here butterflies on the fence appearance can be seen. This is the epithelium, and lining the epithelium, these are the tumors. So, tumor cells are growing along the bronchoalveolar lining. This is the bronchoalveolar lining. These are the tumor cells. Because of this presence, it butterfly appearance on the fence, and this is filigree pattern or lipidic pattern. Next one is identification features. If we do H&E staining, you can observe this is the gland. So, this is the gland. Lining the gland, there are malignant cells. Malignant cells are lining the gland. So, this is the first one. So, this is the example. There are also types in this. We are having well differentiated, moderately differentiated and poorly differentiated. In squamous cell carcinoma, in poorly differentiated, we can observe it by cytokeratin, P53, P63 and P40 markers. Here we can observe these by TTF1 gene and napsin A. So, these are the identification features. So, this is all for adenocarcinoma of lung. So very easy. We discussed the introduction part and pathogenesis like genes affected and paraneoplastic syndromes, and lastly identification feature. The difference between the squamous cell carcinoma, adenocarcinoma, small cell carcinoma and large cell carcinoma in the lung tumors. In the previous classes, I dealt everything about this carcinoma separately. So this is all for just a revision type, and let's start. In squamous cell carcinoma, mostly males are getting affected. In adenocarcinoma, females are getting affected. In small cell carcinoma, males are getting affected. In large cell carcinoma, males are getting affected. Okay, only in adenocarcinoma. Next one is location, whether it is centrally located or peripherally located. In squamous cell carcinoma, it is centrally located. Adenocarcinoma, it is peripheral. Small cell carcinoma also centrally, and large cell carcinoma, it is peripherally. If the carcinoma starts with S, it is centrally located. So this is the hint that you can easily remember. Next one is smoking affected. Smoking starts with S, and squamous cell carcinoma and small cell carcinoma starts with S. So squamous cell carcinoma is smoking associated, adenocarcinoma is non-smoking associated, small cell carcinoma is strongly smoking associated, and large cell is both, whether it is smokers or non-smokers, it doesn't affect it in any way. Okay, next one is paraneoplastic syndromes. These are very important. In squamous cell carcinoma, they are hypercalcemic. Parathyroid hormone is getting affected in the squamous cell carcinoma. In paraneoplastic syndrome of the adenocarcinoma, migratory thrombophlebitis is getting seen or is association. And in small cell carcinoma, you can see Cushing syndrome and SAIADH association also can be seen. And in large cell carcinoma, you can observe gynecomastia. And next one is pathogenesis. In squamous cell carcinoma, the pathogenesis is P53 is getting affected. In adenocarcinoma, KRAS, EGFR and ALK gene are getting affected. In small cell carcinoma, LMYC association can be seen, and in large cell carcinoma, we are unable to see any kind of association. Next one is H&E staining. In this H&E staining, we can observe Kell pearls and desmosomes are seen in the squamous cell carcinoma, and glands, if it is the glands, they are lined by the malignant cells which are pleomorphic in nature. So this is the thing that we can see in the adenocarcinoma of the lung. And carcinoma, we can see the cell is very small and scanty cytoplasm, the hyperchromatic nucleus in which there is breaking of the chromatin or salt and pepper appearance of the chromatin, and we can also see the necrosis and molding of the nucleus, and Ajopati effect is also seen. What is this Ajopati effect? In this, the lung cell will become fragile, due to which it breaks, and due to this breakage the DNA comes out. This DNA will deposit in the walls of the blood vessel. It is deposited here, due to which they produce basophilic strain or basophilic color. Okay, so this is the Ajopati effect. And in large cell carcinoma, we see large pleomorphic cells and IHC marker. This is the last difference. In squamous cell carcinoma, we observe keratin pearls, and depending on this differentiation, they are well differentiated, moderately differentiated and poorly differentiated. In this poorly differentiated, we can see cytokeratin, P63 and P40 IHC markers, and in poorly differentiation of the adenocarcinoma, we can see TTF and napsin A IHC marker. You can see NSC, chromatin, chromo and synapto. So this is very common for neuroendocrine tumors like P square S C square. Let me write it here. P square S C square. P is for pheochromocytoma and another P is for paraganglioma, S for small cell carcinoma, and one C is for carcinoma tumors, another C is for carotid body tumor. So these can be seen in all the neuroendocrine tumors. So this is all for today. Please do consider subscribing to the channel to educate you. This is K. Harshita signing off. Thank you so much.